welcome to Canadian Justice. I'm Christine Van Gyn, and today I'm joined by two co authors of a book on healthcare choice in Canada. The book is a collection of essays about innovative policy solutions to improve Canada's failing healthcare system. It considers how the courts can be used to uphold patient rights, how patient choice drives quality in medical care, the role of prevention in healthcare, comparisons to other healthcare systems around the world, including European models that would allow seniors to age in their own home. Healthcare is something of a sacred cow in Canada. We have a government monopoly system providing healthcare to patients, and many of our political leaders fear making any changes to that system. But change and innovation are necessary. In 2023, the Fraser Institute found that the median wait time for healthcare from a specialist is now the longest ever recorded at 27.7 weeks. We know that patient health and quality of life deteriorates while patients wait, and something needs to change. And this book, Healthcare Choice in Canada, provides some solutions. We're joined by two of the co authors, Sean Whatley, a physician, author, and Munk Senior Fellow. And we're also joined by Colin Craig, the president of secondstreet.org. Thank you both so much for joining me today. Dr. Whatley, let's start with you. You wrote a chapter called Patient Choice Drives Quality in Medical Care. Can you explain how?
So, in a nutshell, choice changes our priorities. So, it shifts doctors and nurses to think of nothing else than providing outstanding quality service for our patients. So, healthcare is a service industry. We don't offer products. And if you could just imagine yourself sitting at a desk and you've got a line of patients to be seen that, stretches off into the horizon. When you look at that, you're a good doc, you're a good nurse, you're going to focus on safe, effective, timely, patient centered care. So, all the aspects of quality, but you're also going to worry about whether you're going to have energy to get through that list and whether you're following all the rules and regulations and making your administrator happy. On the other hand, if you have a much shorter list because you know that your patients could go to your next door neighbor or the three other doctors in your clinic, now you're thinking, I need to figure out how I can improve the quality I offer. Can I offer evening appointments? Can I, make sure I run on time? Can I buy new equipment to make life better for them? So it shifts the priority, and that's how choice drives quality in patient care.
So, Colin, one of the things that's so strange to me is that the public seems to understand the importance of competition in almost every other field, that competition improves quality. So, why do we not understand this in healthcare?
It's a very good question. I think because we tend to think of healthcare as something different, right? I mean, so often opponents of health reform have positioned this debate as either the Canadian model or the US model. But anyone who has seen a world map, of course, knows there's nearly 200 other countries, many other developed nations, and many of those countries have universal healthcare systems. And so that's really what I think Canada needs to be doing. And we talk about that in the book is looking at some of these other universal models instead of the US. So looking to Europe, Australia, Japan, and so forth. And usually what we find in those other countries is that they're performing better than Canada, but not only that, they do have elements of choice and competition. So you end up with better services overall for patients.
So, Colleen, you actually had two chapters in this book, but
Mhm.
the chapter and one of them was about the comparisons to the EU, but another chapter was called More Prevention to Ease Healthcare Demand in the First Place. And I thought that was like such a fascinating argument. Can you explain what you mean?
Yeah, so the reality is that yes, we need to fix our healthcare system, but I think we need to look a little bit inwards as a population too, because a lot of the healthcare services in this country, a lot of those resources are used to treat people with diseases and health problems that are preventable. If we were more active as a society, if we had better diets and so forth, then we would have, say, lower cancer rates, lower problems with heart disease, lower diabetes rates, and all those resources that are used for treating those cases. If we could avoid some of that, then those resources could be used for treating people who have genetic health problems, where maybe their heart disease problem is genetic or the cancer problem is genetic. So there'd be more resources to help patients that don't really have a choice.
It's a really fascinating argument, and not the one that I expect to hear from you, Colin. We've got to go to commercial break, but we will be right back. Welcome back to Canadian Justice, where we're discussing a new free book that you can obtain online at the ccf.ca/free healthcare book. You can claim your free copy online. I want to talk a little bit more about this chapter of the book that you've written, Colin, on preventative healthcare. Now, Sean, you're a physician. What is your take on the role of prevention in healthcare and how it could actually improve our system?
So I'm going to separate that to say that prevention is absolutely important. You can exercise, for example, will reduce your rate of 13 different kinds of cancer. So that's just cancer and exercise. How do you make that connection? But statistically, it works. And so I would argue that the case for prevention is actually a moral case. So if you see someone living in a house with the roof on fire, you run in and say, "Hey, your roof's on fire. Get out of there. You know, you're gonna get burned." And that's kind of the same approach with prevention. I worry, though, about saying that we can prevent our way to health savings. I agree with Colin. Perhaps we could get a shift in allocation and perhaps use our resources a bit more efficiently. But there is solid research that suggests that if you save a person from harming their health and you get them to live another 40 years, the overall economic impact is actually negative. So it actually costs more to keep people alive for 40 years as opposed to being heartless and cruel and letting them die young. So I think the case is a moral one. It's the right thing to do. We need to keep people healthy, but I would be cautious about banking it all on economics.
Colin, what's your reaction to that?
Well, I would agree with what Sean's saying that there certainly is a moral case. I don't look at this as a way to save money in healthcare, but rather to have the resources freed up to help people who don't really have a choice. You know, the sad thing with cancer is that quite often you could be as healthy as you want, exercise, have a great diet, but because of a bad luck of the draw with your genes or whatever, you may have a genetic form of cancer. And it would be great if the healthcare resources were more focused on people in that type of a situation rather than people that maybe could have avoided, having a disease like that, diabetes, other health problems. So that's really what we're thinking about is not a dollar savings overall for governments, but just allowing the resources to focus more on patients
Now,
that
Colin, one of
choice.
the things that you talk about in your chapter is these small financial incentives that can lead people to make healthier choices, like exercising more, eating healthier, quitting smoking. And you say that there are examples in other countries of policies where there are these types of small financial incentives for lifestyle changes. Can you give me some of those examples?
Yeah, so some of your viewers may know, Christine, that there's a grocery store chain called Safeway. It's in different parts of Canada. It's an American grocery store chain. And in the US in the past, their former CEO wrote about how they introduced some financial incentives for the health insurance plan for the employees at Safeway. And what they found was that by introducing some small incentives, it could lead to some patients changing their behavior. So if they could save money on the premiums they were paying for healthcare if they didn't smoke, or if they had lower cholesterol rates, if their body mass index was lower, and et cetera, et cetera. If they lived healthier lives, then they would save some money. And what they actually found was that it did change behavior. So we talk in the chapter and we've talked as an organization about how you have to be very careful with this topic because you don't want the government intruding in people's lives. But we certainly think that it's important for governments to experiment at least with different ways to maybe encourage people to, um, you know, engage in some more healthy activities so there would be less strain on the healthcare system.
So, Dr. Watley, we've only got about a minute left, but I'd be interested in your take on these types of financial incentives and how they might work.
Well, it brings up the topic of horizontal equity, right? Is it fair that you and I pay exactly the same amount for our health care when I don't use it very cautiously at all? I go to the doctor over and over and I don't take care of myself and I ask for repeat x-rays of my knee and then I end up getting my knee replaced at the same time as you, or maybe I should say Colin, let's pretend we're identical twins. And so that's the concept of horizontal equity. And when you start talking about these small incentives, you start touching on this issue that if we have a shared resource, we should all work together equally hard to protect it.
Really fascinating. We've got to go to commercial break now, but when we come back, I want to talk about the role of the courts and that they could play in addressing patient choice. This is an issue that I have worked on, and I have a chapter in this book about. So I'd be interested to know both of your perspectives on that. We will be right back. Welcome back to Canadian Justice, where we're discussing a new book on healthcare choice in Canada, which Colin, Sean, and I have all contributed chapters to. Now, my chapter in the book is about how the courts can address patient choice and the problem of patients suffering and dying on wait lists. There are two conflicting court decisions. The Supreme Court decision in a case called Shaoli, which found that the rights of Quebec patients were violated when the government monopoly system left those patients suffering and dying on wait lists. The court in Shaoli found that the government must allow for private options, including private insurance. But the Shaoli decision only applies in Quebec. There's a conflicting decision from the BC Court of Appeal in a case called Cambie, which I was involved in. In Cambie, the court found that although patients' rights to security of person and even life were violated by being left on these wait lists, that the violation of their right to life and security was either consistent with the principles of fundamental justice or it was saved by Section 1 of the Charter because the court essentially found it was worth this suffering and even dying to have a government system. The Supreme Court never reconciled these two fundamentally incompatible decisions because they declined to hear the appeal in the Cambie case. So, Colin, this is all really troubling. What do you make of the inconsistency, and what does it mean for patients on the ground in practice?
Christine, I don't think there's any justifiable grounds for any court to say to someone that you cannot use your own resources to try to improve your health. It's just fundamentally offside with the free and democratic society. It makes no sense to me at all that the BC courts would conclude what they did. I think that it's a very good thing in Canada that we have a universal healthcare system, everyone's covered. But to say to people that you cannot use your resources to use alternative services if you don't want to use that system, I don't think there's any grounds that someone could make that decision or make or
Sean,
back that up.
what do you make of this same issue that the courts declined to, or that they have these two competing decisions, and what the impact of these competing decisions is on patients, where essentially patients in Quebec have different rights from patients in the rest of the country?
Yeah, or patients in Quebec who need particular surgeries have different rights than other patients in Quebec. So, first of all, I have to thank you and your team for the tireless work you've done on this, and I know there's many people supporting you. Just two brief comments. Number one, Chauli shifted the conversation in Canada. It now became okay to talk about wait times within a public system. So, Justice McLaughlin's famous line, access to a waiting list is not access to health care. So there was a normative aspect that shifted in Canada in 2005. But Colleen Flood, actually, Dean of Law at Queen's University, I fundamentally disagree with her on so many things politically, but that's why I love to quote her on this. And she says, you know what? This was right before Cambie. She said, we don't need to worry too much about this. If we, the ban on public's or private health insurance, if it's overturned, not to worry because we have a whole system of levers that are blocking development of a second tier. She says many countries use a range of other indirect methods apart from expressly prohibiting private health insurance to protect their public system. And so she goes on to list, for example, protecting the Future of Medicare Act in Ontario that bans doctors from opting out of Medicare. So there's a whole web of legislation, but also regulations and policy that blocks the development of true choice. So all this to say is that Christine, you have work ahead of you for 4 or 5 decades fighting this, and there are many, many laws to attack. But it speaks to a fundamental paradox within Canada itself.
Yeah, I mean, that quote from Flood is basically, I mean, it's saying the quiet part out loud, right? It's how can we block patients in any way possible? Colin, what do you think of the role of the courts? I mean, in this case, they declined to hear the Canby appeal. Do you think there is a role for the courts in these issues?
Certainly not the way that they've approached them. I think the Supreme Court was right many years ago with Chow Lee to say that patients should have choice. I'm summarizing, but I think the BC courts have dropped the ball. I mean, at the end of the day, what we end up with is patient suffering. Like there are literally people in this country who are being refused life-saving healthcare in Canada by the government, and they're having to spend their own dollars abroad because they're not allowed to spend those dollars here. Not everyone can afford that. So the government is actually, causing a lot of patient suffering in this country.
Yeah, it's important to remember that people do leave Canada for medical treatment. We will be right back. Welcome back to Canadian Justice, where we're discussing a new book on healthcare choice in Canada, which recommends some innovative policy solutions to improve our healthcare system. We're all three of us, Colin, Sean, and I, are co authors of this book. We all contributed chapters. Now, there was a chapter, and actually, there are a few chapters in the book that consider policy solutions in healthcare drawn from international examples. And there's a chapter on how European countries are allowing to seniors to age in their own homes to reduce institutionalization and costs. There's a chapter about European solutions to wait times. So, Sean, what do you think we in Canada can learn from the European models?
Well, two big things. Number one, no one copies Canada. So it's kind of disturbing to look around the world and say, hey, aren't we standing out for anything? But each country does something well. So primary care is done well in Israel, community services in Brazil, choice in France, health promotion in the Nordic countries. And I think the thing that jumps out when you look around the world is number one, the variety, and number two, the concept that every healthcare system is a reflection of the constitutional environment of that particular country. So, yes, we need to learn. Yes, we need to be willing to change like other countries do. But I would caution against copying and pasting something from another country and expecting it to work in Canada.
Colin, what do you think we can learn from European models? Because you do have a chapter in here about this exact issue.
Yeah, I think there's a few different things we can learn from Europe. One is that instead of funding systems, they fund patients essentially. They will fund hospitals differently, giving them money every time they help a patient, rather than what we see commonly in Canada, where the hospital gets a big check at the beginning of the year and they're told, good luck. We hope you can help a lot of patients this year. When you fund hospitals based on what they accomplish, how many patients they're helping, then you change the incentive model and it can lead to higher productivity levels. A second policy that's very good in Europe is we were just talking about people leaving the country for care. In the European Union, every patient has the right to go to another country, pay for the surgery that they need if they can't get it in a timely manner in their home country. And then when they get back, they can hand in their receipts and get reimbursed up to what that home country would spend to provide locally. So suddenly, if you're a European patient, you're not just looking at the options in your country that are local to you. You've got thousands of other opportunities to go to other countries. So it gives patients more choice, can help them avoid long wait times if they happen to meet one.
Now, Sean, as Canadians, we seem to always compare ourselves to the US, and nowhere do we do this more than in healthcare. But why is it that the US is almost always the comparator group when it comes to healthcare reform when there are so many other examples worldwide? Is it just geographic proximity? Is it something about the Canadian identity that we always make this comparison? Is it something about the failures of the US system that we are so concerned with?
Yeah, so I'll say two things building on the suggestions that you already made. And number one, our system is actually very similar to the US. Most people will say, no, no, it's not. We're both based on a third party payer approach. So 45% of patients in the States get their care from government, Medicare, Medicaid, veterans. 30% are employee based benefits. So again, third party payer. The second big reason, though, and this is fascinating, there's a new book out from the University of Manitoba called Radical Medicine, looking at the international origins of socialized medicine in Canada. So when we developed our system in the 40s and 50s, we actually drew upon people from the United States that wanted to leverage the New Deal in the States, the building of the welfare state, to create true socialized medicine in America by showing how wonderful it was in Canada. So a lot of the people, Henry Sigrist, Mindel Sheps, Fred Mott, a whole bunch of names, worked with Tommy Douglas and actually ran the Saskatchewan Ministry of Health for a number of years to show how wonderful this is in Canada so that hopefully the Americans would adopt it. So built into that is the emphasis of the difference between Canada and the States. Canada is very different than America. And so that's built into our roots, a huge opportunity for discussion there for sure.
Really fascinating. Sean, Colin, thank you both so much for your contributions to the book and for coming on today to talk about it. We've heard today about some innovative policy solutions suggested in a book called Healthcare Choice in Canada, which I helped to edit and co-author. You can claim your own free copy of the book at the ccf.ca/healthcarebook. And if you do, please tag me on it on Twitter saying which chapter was your favorite, and it doesn't even have to be mine. So thanks for watching, and remember, a freer Canada starts with you.